Good afternoon, everyone. I will be talking about the lab diagnosis of eye infection and what are the important points to remember in that. So
Dr.
first,
Ivneet, I would just like to request you to adhere to the time since we are already
yeah,
running
sure.
quite late.
So the diagnosis of ocular infection is challenging due to diverse presentation and moreover lack of prompt intervention may result in long-term vision impairment. Therefore, it is crucial to diagnose and treat ocular infections as soon as possible. And this also involves choosing the right antibiotics and antifungal based on the correct diagnosis so as to prevent emergence of resistance. As you know, that ocular infections are diagnosed clinically. I will be touching the different types of eye infection, organism associated and specific testing approaches. For that, I will be dividing into group 1 and group 2, which include non-sterile, that is outer eye, and sterile side, that is the inner eye. And cornea will be included in group 2 also. Group 1 conditions include blepharitis, myiasis, canaliculitis, dacrocystitis, and preseptal cellulitis. And the organism most commonly associated with this Staphylococcus aureus, Cutibacterium acnes, Coagulus negative Staphylococcus species, but now the name has been changed to other Staphylococcus species. तो जो हम फॉर्म में लिख के भेज रहे हैं, that is OSS and not cons. And then the different type of mite, that is demodex, and also pubic lice is associated. So in Western world, when pubic lice is found on the eyelid, it signifies the child abuse is there. Then again, myiasis cases have been reported recently from India in northeastern regions. Coming to conjunctivitis, as we all know, in 2022, we faced acute viral conjunctivitis, that is Madras eye, caused by adenoviruses, enterovirus, and Coxsackie viruses. Among bacterial causes, it's gonococcal and non-gonococcal conjunctivitis, and also chlamydia trachomatis. But recently, India has eliminated trachoma as public health problem, and WHO announced this achievement in October 2024 only. And among adults, bacterial causes of conjunctivitis includes again Staphylococcus aureus, Streptococcus pneumoniae, and H. influenzae, and in children, H. influenzae, Streptococcus pneumoniae, and Moraxilla. Coming to group 2, that is keratitis. I will be dealing with infectious keratitis. Bacterial keratitis includes Pseudomonas, Staphylococcus, Streptococcus, Moraxilla in 5% of cases. And recently, case studies have been, this Serratia marcescens is upcoming, and Nocardia and atypical mycobacterium has also been reported recently. Coming to protozoal keratitis, it's acanthamoeba, that is free-living amoeba is responsible. And in gram stain, we can see this double-walled cyst with inner polyhedral lining. It can also be stained with 10% KOH along with calcofluor white, and the culture media that is used is non-nutrient agar. Coming to keratitis by oomycete, this is also emerging parafungus from Asia-Pacific region, that is Pythium, and the only species infecting human is Insidiosum. And we have to collect 2 specimens, one is for gram stain, other for culture, and we can also go for PCR testing and also zoospore formation within 3 hours of incubation. So these are the pictures that we can see septate hyaline hyphae, and this is the growth on normal blood agar, and also the zoospore formation after 3 hours of incubation. Fungal keratitis, I will be, the common agents of keratomycosis includes hyaline hyphomycetes, pheoid fungus, and yeast-like fungus. In hyaline, we have aspergillus, fusarium, acremonium, bacillomyces, penicillium, and pseudosporium. Pheoid may alternaria, bipolaris, curvularia, and fonsecia, and yeast may candida albicans and non-albicans species. Not going into the clinical features. So what is important is fungal keratitis that is caused by fusarium species neither show infiltrate nor raised lesion. Aspergillus keratitis show ring infiltrate and feathery borders as shown in this figure. And Aureobasidium keratitis follows following LASIK surgery. And the morphology and the chlamydospores we can see in this picture. Now, the lab diagnosis of fungal infection, we have to collect the specimen from base and the margin of the ulcer aseptically, never from the surface. And it should be sent to lab, and we will perform 10% KOH and calcofluor white stain upon requesting. We demonstrate yeast cells, pseudohyphae and hyphae, and of course, calcofluor white stain smears, they are examined under fluorescent microscope, and it's superior to conventional staining techniques as shown in this figure. So this is the KOH mount, and this is the calcofluor staining showing septate hyaline hyphae. Fungal culture, again, 2 sets of SDA, one with antibiotics, one without antibiotics, and of course it is stored at 2 different temperature, and we used to dispatch the report after 7 days to 14 or maybe more in 30 days. These are the LCB mounts of various fungal infection. We can see microconidia of fusarium. This is alternaria showing conidiophores in transverse and longitudinal septae. This is the brush border appearance in cases of penicillium infection. This is curvularia, and this is bipolaris. Microsporidial, recent classification in 2012 suggested that microsporidia are single-cell eukaryotic parasite. Before that, it was considered to be as fungus. And the most common stain still used to stain it is 10% potassium hydroxide with chalcofluor staining. And they also stain with 20% sulfuric acid. So whenever you are sending sample, you have to mention modified Zn staining. Fluorescent microscopy can also be used. So this is the microsporidial spores, which can be seen in clusters of unstained hollows in gram stain, and the same slide can be stained for modified Zn. Right? So we can, here it is showing oval red, reddish pink microsporidia. Coming to endophthalmitis, exogenous, endogenous. Exogenous causes, they are mostly associated with the bacterial, and endogenous mostly associated with MRSA and oral streptococcal infection. Also the fungal causes can come under endogenous. So these are the all the fungus that are associated with exogenous and endogenous endophthalmitis. Intraocular specimen like aqueous or vitreous fluid is required to for diagnosis, and as intraocular samples are often culture negative, so cases that respond to fungal treatment are considered to be fungal in nature. Uveitis and retinitis, most common causes Toxoplasma gondii and CMV infections. Now, what are the challenges in specimen collection and transport is that limited sample volume is there, irrepressible sample, we cannot ask for a repeat sample, bedside specimen collection, frequent antimicrobial exposure prior to sample collection is there, and limited ocular anatomy and pathophysiology training in clinical microbiology laboratories. So swabs are acceptable only for eyelids, lid margin, conjunctiva and superficial lacrimal system. They should be transported in the laboratory within 2 hours, and they should not be dry. And blades and spatula, they are preferred for collection of tissue to isolate virus, fungi and chlamydian free-living amoebae. Cotton and calcium alginate swabs should be discouraged, and one slide, this is very important, should be submitted for each requested stain. Now, these are the organism and their primary culture, which we do in our lab. Now, here, what is the difference between aerobic and anaerobic culture is, for aerobic culture, you can send the sample to the lab. But if you are suspecting an anaerobe, you have to directly put the sample into the anaerobic media, and then you have to send it to the lab. Rather than just sending a simple sample for anaerobic culture media, we will not be able to grow anything on that. Next is for gnats. Dacron rayon flocculated swabs are acceptable for gnat, but flocculated swabs are associated with increased cell cytotoxicity, and therefore it should not be used for viral culture. Transport media should be sent at room temperature in liquid broth or in sterile containers. Remember to remove the syringe or needles, and tissue should be transported intact, and they should be moistened with sterile saline. Approaches to detect ocular pathogens in microbiology laboratory include direct examination, antigen test, culture, gnats, and serology. Direct examination is gram stain. You can see gram positive, gram negative organisms. Then acid fast, modified Kinnian, chalcofluor can also be used, but upon request. Then Gimsa and Papanicolaou. So the importance of these stains are that detection of multinucleation, molding, and margining can only be differentiated between HSV and VZV infection. As you know that processing, we use sterile scissors and we mince the tissue. We need a proper sample for that. And processing of flute specimen is also, we can directly inoculate on the culture plate, or sterile membrane filter technique can be used. And also automated blood culture bottles are available there. So in case you are sending vitreous samples, you can ask for this Bactec and Vitek. And again, the time is obviously different because most bacterial yeast, they grow within 48 to 72 hours. Even 7 days incubation period is required for anaerobes. For fungal culture, it's more, and also for mycobacterium. Antigen test includes EIA, that is enzymes immunoassays, and recently POCT bichiral, that is a membrane-based EIA that captures and detects adenovirus within 10 minutes, has been introduced. Now, regarding NATs, this is very important. No FDA-approved NAT exists specifically for ocular specimen, but they are particularly helpful in deciphering the etiology of culture-negative intraocular infection along with fastidious organism where their sense specificity is 99%. Commercially available NAT, they target chlamydia trachomatis and are highly sensitive, but FDA approved it only for screening of genital specimen. PCR arrays currently do not have role in diagnosis of ocular syphilis. And also there are no FDA approved commercial molecular diagnostics test for acanthamoeba. Although NAT exhibit higher sensitivity than serology in cases of diagnosing Toxoplasma gondii, and multiplex assays, PCR, are recently been introduced where you can detect more than one virus, and the turnaround time is also short, like within 3 hours. Next generation sequencing and shotgun metagenomic approaches, both these current approaches are therefore well suited for the detection of ocular pathogens given the wide array of infections, but they are used for research purposes and not for normal routine purpose. Coming to serological test, they can be retinitis and uveitis. They can be diagnosed secondary to systemic infection. Pathogens include Treponema pallidum, Toxoplasma gondii, and Borrelia burgdorferi. Treponema positive VDRL plus visual dysfunction, diagnostic of ocular syphilis. If CSF VDRL is negative, you can go for other CSF count, and you can see for other parameters. Regarding Toxoplasma gondii, FDA approved kits are there for accuracy. Remember, negative IgG serology rule outs the infection. And also we can go for Goldman-Whitman coefficient, that is GWC, that is ratio of intraocular over serum antibodies more than 3 is diagnostic of ocular involvement. Nematodes affecting eye includes Onchocerca volvulus, Loa. Recently, in 2023, one case has been reported from Chennai, and in India,
Dr. Ivneet,
10 cases.
if you could just try to wind it up.
Yes. So recently only 10 cases of Loa has been reported from India. Similarly, cestodes and trematodes, the diagnostic techniques are identification of morphology, serology, and stool analysis. Coming to ocular drug delivery, this is recently NCDC guidelines, recommendation for management of common ocular infections in India. What is to be remembered that antimicrobial breakpoints for topical agents should be interpreted cautiously as they are based on serum. So fortified preparations should be used, and remember, ocular drug concentration often exceeds serum levels, meaning some resistant isolates on antibiogram may still be treatable with higher local doses. No AST guidelines exist for ocular isolates, so lab should report MIC values with the note that interpretations are based on serum levels. Antifungal, the standard empirical treatment for filamentous keratitis is 5% netamycin. However, the mycotic ulcer treatment trial 1 demonstrated that 5% netamycin is superior to 1% voriconazole in improving visual outcomes and reducing perforation in fusarium infections, whereas mid-2 trials, they show no significant added benefit of systemic voriconazole when used alongside topical netamycin, exception in this fusarium cases. Antiviral agents, of 3% topical acyclovir ointment, oral acyclovir, valacyclovir for 1 week, but they should require hospitalization and IV treatment because of increased risk of acute retinal necrosis is there. So to conclude where we stand, despite of all the advancement, there remains significant work to be done, including establishment of bacterial breakpoints which are not there, relevant to the ocular infection, standardization of molecular test, expansion of mold susceptibility testing, investigation of neglected ocular infection, and development of implementation of rapid diagnostic in diagnosis. Remember, the widespread and injudicious use of conventional antibiotic in ocular infection together with improper dosing regimen, polypharmacy, and the absence of global ocular antibiotic prescription guidelines have resulted in AMR among gram-positive and gram-negative organisms. Thank you so much.
Thank you, Dr. Ivneet, for such a comprehensive and interesting talk. Next, I would like to invite Dr. Kaur for her talk on pulmonary diseases with ocular impacts.